Morning, everyone. Today's topic of seminar is renal failure. First is acute kidney injury. It is a sudden deterioration of renal function, which is oliguria, low urine output, and azotemia, which is accumulation of nitrogenous acid-base disturbance, and nitrogenous waste and acid-base disturbance. Loss of glomerular filtration. The basic pathophysiology is ischemia, perfusion, and nephrotoxin. The which results in cortical vasoconstriction, obstruction, and finally the reduced glomerular filtration rate. The causes of which includes intrinsic and parenchymal and post-renal. Pre-renal etiology is due to decreased blood flow and hypoperfusion of the kidney, and which ultimately result in volume depletion, vasodilation, and decreased cardiac output, which can progress to intrarenal damage. Interrenal etiology. Kidney tissue is affected directly, glomerular, vascular, or hematological problem, and intrarenal etiology includes acute tubular necrosis, which is due to ischemia, and that is due to decreased blood flow, and nephrotoxic agent, which includes antibiotic and NSAIDs, and contrast-induced nephropathy, and also rhabdomyolysis. Post-renal etiology is due to obstruction of the outflow, and increased intratubular pressure leads to decreased GFR. It reverses when the obstruction is removed. The course of AKI is initiation phase. We start from the event to the sign of decreased renal perfusion. It takes from several hours if appropriate management is done at the appropriate time. Maintenance phase is which includes oliguria or anuria, in which blood urine nitrogen creatinine increases, and oliguria is common, which is less than urine output less than 400 ml. It finally results in fluid overload, electrolyte imbalance, and acidosis. And in this, renal replacement therapy is required. Maintenance phase is a course of AKI recovery phase. Return of tubular function. It takes usually 4 to 6 months for blood urine nitrogen and creatinine to return to normal. Residual impairment of GFR and early dialysis may prevent the traditional diuretic phase of AKI. Now the assessment of the patient. First, the patient history and their predisposing factor are disease state, hypertension, diabetes, immunological disease, hereditary disorder, and hypertensive episodes, and exposure to nephrotoxic agent. Clinical presentation of AKI. Vital signs may be altered in AKI, blood pressure changes, which depends on the etiology, hyperventilation to compensate for metabolic acidosis, and blood temperature may be altered. An assessment for volume depletion and volume overload should be there. The patient general appearance is assessed for signs of uremia, color and texture of skin, bruising, petechiae, and edema, and dehydration, fluid overload. Acute kidney injury is an abrupt reduction in kidney function, as evidenced by laboratory values, serum creatinine, blood urine nitrogen, and urine output. Acute kidney injury is diagnosed if increase in serum creatinine is of at least 0.3 milligram per deciliter within 48 hours, and the 50% increase in baseline serum creatinine within 7 days, or a urine output of less than 0.5 per kg per hour for at least 6 hours. 1% of hospitalized patients develop AKI, and it is quite common in critically ill patient, and mortality generally exceeds 50%. Classification of AKI is according to Rifle criteria, which include risk, injury, failure, loss of kidney function, and end-stage renal disease. AKIN is the acute kidney injury network, and the KDIGO, kidney disease improving global outcome. Pre-renal AKI is characterized by reduced blood delivery to the kidney, and the common cause are volume depletion, decreased effective circulatory blood volume, and the functional due to drugs. And the prompt correction of volume depletion can restore the kidney function to normal, because no structural damages kidney has occurred till now. Intrinsic AKI damages within the kidney, and the structure of nephron is destroyed. Vascular damage, it may be due to vascular damage, which accounts for the 50% of AKI, which is due to ischemia, toxins, and exogenous or endogenous, and aminoglycoside, contrast-induced, and amphotericin B, acute interstitial nephritis, NSAIDs, and infection. Post-renal AKI is due to obstruction of urinary outflow, outlet obstruction, benign BPH, and prostate cancer, anticolony duct, and ureteral obstruction. And it may be due to malignancy, pelvic renal obstruction. Post-renal AKI accounts for less than 10% of cases of AKI. Rapid resolution of post-renal AKI without structural damage restore kidney function. Serum creatinine should be monitored daily for quantifying the improvement and worsening of the kidney function. And polygram is less than 400 ml in 24 hours, and urea is less than 50 ml in 24 hours. Clinical presentation and diagnosis of AKI. Peripheral edema is seen, weight gain may be there, nausea, vomiting, diarrhea, and anorexia might be there. Mental status changes and fatigue, which includes shortness of breath, may be there. Laboratory tests, elevated serum creatinine and elevated blood urine nitrogen, decreased creatinine clearance, and blood urine nitrogen creatinine ratio is greater than 20:1 in pre-renal and less than 20:1 in intrinsic or post-renal AKI, hyperkalemia, and metabolic acidosis. How to prevent it? Non-pharmacological measures for prevention. Hydration to prevent contrast-induced nephropathy. KDIGO guidelines recommend using normal saline or sodium bicarbonate infusion. Normal saline regime is 1 ml per kg per hour for 12 hours before and after the procedure. Sodium bicarbonate regime is used is 3 ml per kg per hour for 1 hour before procedure and 1 ml per kg hour for 6 hours post-contrast. Pharmacological therapy for prevention of CIN, contrast-induced nephropathy. Ascorbic acid can be used 3 gram orally pre-contrast and 2 milligram orally for 2 doses post-procedure doses. N-acetylcysteine in the dose of 600 to 1200 milligram orally every 12 hours for 2-3 days, and the first 2 doses are given pre-contrast. Current KDIGO guidelines suggest moderate control of blood glucose to level of 110 to 149 with insulin prevent ICU-acquired AKI. Goal of treatment is minimize the degree of kidney insult, reduce extra-renal complication, restoration of renal function to pre-AKI is the ultimate goal. Criteria for acute injury. Rifle criteria, which includes stage 1, increase in serum creatinine to 1.5 times baseline or urine output of less than 0.5 ml per kg per hour for 6 to 12 hours. And the injury includes, which is stage 2, increase in serum creatinine to 2 times baseline and the urine output of less than 0.5 ml per kg per hour for 12 to 24 hours. Increase in failure is increase in serum creatinine to 3 times baseline or increase in serum creatinine by 0.5 milligram deciliter to more than 4 milligram per deciliter. Urine output of 0.3 ml per kg per hour for more than 24 hours or anemia for more than 12 hours. Loss is in which kidney replacement therapy is required for more than 4 weeks and in end stage more than 3 months. Treatment approaches, currently there are no definite therapy, but the supportive care is the mainstay of management regardless of the etiology. Supportive care in AKI. Supportive care includes adequate nutrition, correction of electrolyte, acid-base abnormalities, particularly hyperkalemia and metabolic acidosis, fluid management, correction of any hematological abnormalities, and the medical management of infection, cardiovascular, and GI condition. All drugs should be reviewed in the form of dosage and should be given after the estimation of the patient GFR. Non-pharmaceutical therapy to optimize the tissue perfusion and discontinue any medication which leads to diminished renal blood flow, and appropriate fluid and electrolyte should be given, and the renal displacement therapy in severe AKI should be started. Hemodialysis and peritoneal dialysis can be done. Absolute indication for dialysis includes blood urine nitrogen greater than 100 milligram per deciliter, potassium greater than 6, magnesium greater than 9.7, metabolic acidosis with pH less than 7.15, and diuretic should be used for resistant fluid overload. Common indication for renal replacement therapy are acid-base abnormalities, electrolyte imbalance, intoxication, overload of fluid, and uremia. Pharmacological therapy, loop diuretics are effective to reduce fluid overload. Thiazide diuretics, when used as single agent, are generally not effective and for fluid removal and should be combined with other diuretics. Mannitol is not recommended for treating volume overload associated with AKI. Potassium sparing diuretics are not recommended. Low dose dopamine is not indicated in treating of the AKI. Equipotent doses of loop diuretics all have similar efficacy. Ethacrynic acid is especially used for sulfur allergic patient, and continuous infusion of loop diuretic can overcome the diuretic resistance. Associated with less, which is associated with less adverse effect than the intermittent bolus. Initial IV dose, loading dose of 40 to 60 milligram furosemide and the continuous infusion 10 to 20 milligram per hour. Strategy to overcome diuretic resistance. Different agents should be combined because they act synergistically. And thiazide, it works on DCT and loop diuretic sending loop. Electrolyte management, nitrate daily, and hyperkalemia is the most common and the serious electrolyte abnormality which requires your urgent attention. And hypernatremia and fluid retention commonly occurs. Phosphorus and magnesium should be monitored. Prevention of acute renal failure. The best ways to avoidance is avoidance, especially in individual at high risk, which includes avoiding the medication that are known to precipitate TKI. Nephrotoxicity is a significant side effect of aminoglycosides, ACE inhibitor, amphotericin B, NSAIDs, cyclosporin, tacrolimus, and radiographic contrast agent. Now the CKD part. Irreversible attrition of number and function, frequently leading to end-stage renal disease. End-stage renal disease is the condition in which there has been an irreversible loss of renal function. And okay. Yes. ESRD incidences, maximum is in diabetes mellitus, which is 38%, and hypertension is 25%, and glomerulonephritis is 14%. Pathophysiology of CKD. CKD progresses to ESRD. The basic pathophysiology is vasoactive molecules, cytokines, growth factors, and renin-angiotensin axis, which ultimately leads to sclerosis and results in decreased population nephron and reduction of renal mass. Uremia is metabolic and which leads to metabolic and endocrine dysfunction, in which kidney function are also impaired. Malnutrition, impaired metabolism of carbohydrate, fats, and protein, and metabolic bone disease. The endocrine hormone involved in ESRD is PTH, insulin, erythropoietin. Clinical manifestation of chronic renal failure, uremia. Chronic renal failure often develops slowly, and patient can remain asymptomatic until renal failure is far advanced. Pure electrolyte and acid-base disorders, sodium and water homeostasis. In most patients with CKD, sodium and water are increased, and which leads to edema and hypertension, and glomerular balance impaired and promote sodium retention. Sodium retention will lead to cumulative positive sodium balance and extracellular fluid volume expansion. Potassium homeostasis in CKD. Hyperkalemia is common in CKD patient. Dietary intake, which may be due to dietary intake, protein catabolism, hemorrhage, transfusion of stored red blood cell, and metabolic acidosis. ACE inhibitor and ARB and some diuretics. Hypokalemia might also be there, but it is less common. It is usually caused by mildly reduced dietary potassium intake or association with excessive diuretic therapy or gastrointestinal losses. And metabolic acidosis, common disturbances, and metabolic acidosis commonly occurs. It is due to reduced ability to produce ammonia Hyperkalemia further depresses urinary ammonia excretion. Bone disease and disorder of calcium and phosphate metabolism. The disorder of calcium, phosphorus, and bone disease is common in CKD. The major disorder of bone disease can be classified into high bone turnover with high PTS level, includes osteoarthritis fibrosa, low bone turnover with low or normal PTS level. When the GFR decreases to less than 25% of normal, phosphorus excretion is impaired and hyperphosphatemia occurs, which leads to secondary hyperparathyroidism. Ischemic cardiovascular disease. CKD is a major risk factor for ischemic cardiovascular disease. Ischemic cardiovascular disease is CKD caused by both traditional risk factor and CKD related risk factor. Hypertension and left ventricular hypertrophy may occur. Pericarditis may be there, which may require renal replacement therapy. Hematological abnormalities, anemia. Anemia in CKD is a normocytic, normochromic, and will observe beginning at stage 3 CKD, and it is irreversible at stage 4. Hematological abnormalities is anemia. The primary cause of anemia is patient with the insufficient production of EPO by the diseased kidney. Neuromuscular abnormalities includes the restless leg syndrome, which is ill-defined and sensation of discomfort in legs is seen, and legs and feet requiring frequently movement. GI and nutritional abnormalities. Gastrointestinal abnormalities include abdominal pain, nausea, vomiting, and which may be which can be the usually the first symptom of for ESRD patient. Evaluation and management of patient with CKD. History is hypertension, diabetes, systemic infection, and metabolic disease, and exposure to drug and toxins. Let me complete the things. What's the last slide? Reversible causes of renal failure are reversible factors, infection, and
chronic kidney disease can be divided according to GFR into 5 grades. As we all know, more than 90, 60 to 89, 45 to 89, and 30 to 44 are grade 3, divided into A and B, and 15 to 29 and less than 15 being grade 4 and grade 5. They can also be divided into albumin excretion ratio into 3 parts, A1, A2, A3, less than 30, 30 to 300, and more than 300. This is the same pictorial representation of division of CKD into GFR. CKD by means of GFR. Treatment includes, we can slow the progression of CKD by doing the protein restriction with less than around 0.6 to 0.8 milligram per kg body weight, reducing glomerular, interglomerular hypertension and proteinuria, managing complications of chronic renal failure such as disorders of mineral metabolism, hypertension, cardiovascular diseases, uremic pericarditis, CHF, anemia, and associated abnormalities. For slowing the progression, we need to restrict the proteins. Major goal being to slow down the progression of nephron injury. It should be restricted to 0.6 to 0.8 gram per kg body weight, as I told earlier. And we need to give patients enough essential amino acids and energy supply in the tune of 35 kilograms per kg per day. This is the recommended dietary intake for patients of chronic kidney disease. We also need to reduce intraglomerular hypertension and proteinuria, for which we can give AC inhibitors and calcium channel blockers. Managing complications include disorders of mineral metabolism should be addressed as well. Treatment should begin with dietary phosphate restriction to less than 1000 milligram per day. Vitamin D analogs can be added in the diet. It is very important to maintain the calcium phosphate product in the normal range to avoid metastatic calcification. Volume control with salt restriction is very important. The choice of antihypertension is similar to the general population in which we start with ACE inhibitors. In all patients, we should aim at a blood pressure of less than 135 to 80 millimeter of mercury. Patients with diabetes or proteinuria with more than 1 gram per 24 hours, BP should be further reduced down to 124 to 75. This is the recommendation for BP maintenance. Cardiovascular diseases, as we all know, according to, first of all, we should address the risk factors such as lifestyle modification, hyperlipidemia, hypertension, and CKD-related risk factors. For patients having congestive heart failure, we should have a proper water and salt intake, administer diuretics accordingly, add digoxin and ACE inhibitors, and uremic pericarditis should always be addressed by dialysis immediately. Anemia should be addressed by giving recombinant human erythropoietin. Iron status of the patient must be assessed and adequate iron source should be available before treating with erythropoietin. This is for correction of anemia. The starting dose should be 50 to 150 units per kg per week. Target hemoglobin should be between 11 to 12. Optimal rate of correction should be 1 to 2 gram per day over a period of 4 weeks. Renal replacement therapy, if the GFR is below 10 ml per minute, you need to start renal replacement therapy. Absolute indications being severe volume overload, especially congestive heart failure, severe hyperkalemia in the range of more than 6.5, or acidosis with pH of less than 7.1, encephalopathy, which is not otherwise explained, pericarditis or symptomatic uremia, and protein energy malnutrition. This is a picture showing dialysis going on. Hemodialysis requires a constant flow of blood along one side of semi-permeable membrane, with dialysis solution along the other side. Most patients undergo dialysis at least thrice weekly, usually for 3 to 4 hours. Kidney transplantation, 50% of renal patients are suitable for transplant, with 2/3 from disease. For immunization, hepatitis B and pneumococcal vaccine should be considered. The re-vaccination after 5 years. Influenza vaccine should also be given, and Haemophilus B influenza vaccine, conjugate vaccine should also be considered. Live attenuated vaccines are contraindicated in these patients. With this, I conclude my presentation. Thank you.
Thank you. All of you know this is a very important problem, CKD, renal failure, and not only from a theoretical point of view, but from practical aspects also. We all know in India, almost every year, 2 lakh patients suffer from chronic kidney disease, and only 10% of these get treated by renal replacement therapy. So, and of these 10%, only 10% get renal transplant. So we can understand the amount of problem we are facing with chronic kidney disease. You must know the definition of chronic kidney disease. That is, if the urine albumin goes above 30 or more than 30 milligram per 24 hours, or when the GFR goes less than 60 ml per minute for more than 3 months, irrespective of the cause, it will be called CKD. We must also understand the various grades of CKD. We must remember the various causes of CKD, what is acute on chronic kidney injury. So all these are very important because they lead to a lot of complications in whenever these patients suffer from this disease. So the important complications being cardiovascular disease, they suffer from more of these problems. They suffer from more infections, malignancy, and overall mortality is very high in these patients. It is said that if the patients, even on dialysis, those patients who are on end-stage renal disease, 25% they die every year. And you must imagine those who are not on any renal replacement therapy, what is happening to them. So every year we are losing lakhs of people because of chronic kidney disease. So it is very important to understand also how halt the progress of kidney disease once it is diagnosed. We all know the lifestyle changes, the various diabetes, hypertension being the most common causes. You have to control the diabetes, control hypertension, then avoid nephrotoxic drugs, good hydration, and all these things are very important, avoiding infections, etc. And besides that, besides controlling this, we also have to control the proteinuria. So we all know the ACE inhibitors and angioreceptor blockers are being used to control proteinuria. And a newer drug, which is sodium glucose transport inhibitor, right? SGLT2 is a very important drug, and it has been said that it delays end-stage renal disease and mortality by even at least 15 years in these patients. So initially it was used for patients with diabetic nephropathy, but now it is being used even for non-diabetic chronic kidney disease. So this is a very important addition, and we should remember this particular drug, which is important to delay chronic kidney disease progression. I think this is all. If anybody has any resident or any, you have to give any comment or have any kind of a thing to say, please, Nachiket, if you want to say. And residents, if you have any query, please go ahead.
Sir, the comment about him, he said that protein restriction is required. In our Indian patients, protein restriction is not required to that extent. This is because our diet predominantly is not protein-based. Because inside Western countries, every day they're having white proteins, they're having red proteins, they're having meat, and that is that forms the basis of the diet. 2 times a day, they're having it 7 days a week. So that's why they have more proteins than is actually required. But our Indian patients, they have got very limited access to good quality proteins. So that's why now many nephrologists and many nephrology units say that you should not ask the patient to restrict his protein, because already many of our patients are anemic, they are hyperproteinemic. So one difference is that. Number two, I think that N-acetylcysteine, the role of renoprotection of N-acetylcysteine taurine should have been discussed. I mean, even though it is equivocal, but how it's being used extensively. We use it also for contrast nephropathy, and many of our nephrologists, it comes by the name of RenoSafe. So, वो एक discuss होना चाहिए था. बाकी तो the role of magnesium was not very specified by Dr. Pankaj. So I think the importance of hypomagnesemia as well as hypermagnesemia and how the balance of magnesium affects renal function, that is also important. बाकी it was a good presentation. It could have been better because it was too extensive, and also I think that maybe we can repeat it later on with some seniors.
Yeah, I think a very valid point. It is a very important topic. We may have to discuss it again also. The only thing is N-acetylcysteine he discussed in one of the slides, and also the role of giving saline or soda bicarb infusion before doing any contrast studies in these patients. So yes, these are very important things you must remember in your practice also whenever you are asking these patients for any diet studies. And anything else? Anybody? Okay. So if nobody has, and anybody from the those who have joined us online, would you like to please raise your hands? Otherwise, we will wrap up the session. Okay, so thank you everybody. Thanks residents and thanks faculty members and all those who have joined us today, and have a good day. Thank you. Can you close it?